And I will now pivot to Dr. Molly Bewald, who's going to be presenting on advanced care planning, trends, and clinical practice. So it gives me enormous pleasure to be able to introduce Dr. Molly Bewald, who's my course director for this CME course, and is also an associate professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. She serves as program director for the Hospice and Palliative Medicine Fellowship and co-directs the innovative Integrated Geriatrics and Palliative Medicine and Hematology Oncology Palliative Medicine Fellowships. And building off of what we learned earlier today from Dr. Lipman in terms of medical decision making, we'll now hear about advanced care planning from Dr. Bewald. Thank you.
Thanks so much, Sonika. So I am really excited to be talking with you today about advanced care planning, so updates, controversies, and practical tips. And this is a really important topic day to day for a lot of us working in geriatrics and palliative medicine, and some of you who may have been following the literature in our fields, a source of a lot of very juicy debate over the last couple of years. So I'll get into that a little bit. I have no conflicts to disclose. What we're going to be talking about today is a definition of advanced care planning and some of the background about how it came about. We'll talk a little bit more in depth about goals of care discussions, advanced directives, MOLST and POLST forms, and then we'll jump into some of the current evidence around advanced care planning, the controversies around it, and future directions for research. Before I get into the data, I want to share a little bit about why I care personally so much about this issue. This is a picture of my grandparents, Shirley in the purple shirt and Ed in the blue, the first time they met my son George after he was born. My grandma was a longtime hospice volunteer and someone who was actually very passionate herself about advanced care planning. I remember for years she had a bright pink MOLST form right on the front of her refrigerator, and she was very clear. I remember this like as a child being aware that she wanted comfort-focused end-of-life care and sort of having some awareness of what that meant. So kind of a unique woman. She developed Parkinson's, had a hip fracture, and when my family was struggling to make care decisions at the very end of her life in the last weeks, her very clear wishes were really helpful in helping us make decisions when she couldn't speak for herself. And my grandmother's story includes some of the limitations of advanced care planning. She had a very, very carefully prepared living will that said she would never want her life prolonged artificially if she were in a terminal condition or unable to communicate. But that really did not help us know what to do when she broke her hip and developed delirium and was in and out of hospital for months and months without a clearly terminal condition, which I think illustrates one of the big limitations of advanced care planning. There are so many nuances of the situations that we actually find ourselves in medically that it's really impossible to plan for all of them. And I think that's where things get really sticky. But let's pause on that for a second and talk about how this came about. So definition of advanced care planning, origins, and components. So first of all, what is advanced care planning? Advanced care planning is a process, meaning that it's iterative over time, to support adults in understanding and sharing their values, goals, and preferences regarding potential future medical decisions, to help them in choosing and preparing a person to help make those decisions if they lose capacity, and potentially documenting those wishes so that they can be acted upon when decisions need to be made in the future. Why does this need to exist? So the original purpose of advanced care planning was to ensure that people are getting goal concordant care at the end of life when they may not be able to speak for themselves and might lack capacity. Initially, it was focused on establishing preferences for particular medical interventions, but it's become apparent that this is really difficult to do so because the preference for a treatment in a given scenario is usually going to depend on what the likely outcome of that treatment is and how that aligns with someone's goals and values. So the field has shifted a lot in the past few years from an emphasis on specific hypothetical future decisions to really preparing people and their surrogates for actual in-the-moment decision-making. We'll talk more about that as we get to the more recent data. But first, I want to spend a few minutes talking about how advanced care planning in the US came about. So in the United States, Max Henry Weil established a 4-bed shock ward at the LA County Medical Center during the 1960s. And with this advent of ICUs came the idea of medical paternalism, that doctors know best, and also questions about whether these units were serving the purpose of extending life or just prolonging death. Were these interventions doing more harm or more good? If you think back to the ethics training that you might have had in medical or nursing or other schooling, this case might be familiar to you. This is Karen Ann Quinlan. In the 1970s, legal cases established the constitutional right of patients to refuse life-sustaining treatment and to extend this right for patients without capacity to their legal surrogates. The case of Karen and Quinlan was the first major legal decision regarding withdrawal of life-sustaining treatments. In brief, she suffered an anoxic brain injury and was in a persistent vegetative state, and her father sought court appointment as her guardian to discontinue what he called extraordinary medical treatment. He was opposed by the treating physicians, the hospital, and the state of New Jersey, and the Supreme Court of New Jersey granted the request, ruling that the right to privacy includes a right to refuse medical care, and that this extends to incompetent patients. This name might also look familiar to you from some ethics you may have taken at some point. Nancy Cruzan was the first right to die case heard by the Supreme Court in the US. She was a woman who was in a persistent vegetative state after a car accident in 1983. She was unfortunately dependent on artificial nutrition and had no improvement in her cognitive function. And her parents requested to stop artificial nutrition hydration, but the hospital refused to do that without a court order. The US Supreme Court eventually affirmed her right to die and to refuse medical treatments, while allowing states to put restrictions on how explicit and how specific a patient's prior wishes needed to be. The Patient Self-Determination Act was introduced as federal law in 1991 to ensure that a patient's right to self-determination in healthcare decisions was both communicated and protected. So that really came about in response to this. So the Patient Self-Determination Act states that healthcare facilities have to give patients written info about their rights to make medical decisions, and also to indicate in the medical record whether they've completed an advance directive. This act really led to a focus on completing documentation as the main outcome of advanced care planning that people were interested in, including appointing a surrogate decision maker and completing a living will. The field of advanced care planning since that time has expanded its focus to supporting adults to understand and share their goals and values that underline their preferences for medical care. And despite all of this work, advanced care planning engagement remains pretty low, about 50% for all older adults in the US. So I want to now touch on the three central components of advanced care planning, which we'll discuss in more detail shortly. So the first piece is a goals of care discussion, which is our tool to help support adults in understanding and sharing values, goals, and preferences about potential future medical decisions. The second piece is assigning a person, a healthcare power of attorney, which is the process of choosing and preparing a trusted person to make medical decisions. And the third piece is completing advance directives, which is documenting these wishes for medical care so that they could be acted on in the future when decisions need to be made. Two key ethical principles in advanced care planning to be aware of, and I will say the board exams seem to love touching on ethical principles, so pay attention to this bit. One is autonomy, that all patients have the right to make decisions about their treatments, and another is substituted judgment. So this is the process of figuring out what a person might want if he or she had been able to foresee the circumstances and give direction for their care for a patient who doesn't have capacity. So if you've been in a family meeting and asked some version of the question, if your mom were able to sit here with us and tell us what she would choose for herself in this circumstance, what would she say? We're really asking surrogate decision makers to use their knowledge of that patient's values over time to help guide us. That's called substituted judgment. We've discussed them briefly, but in the next section, I'm going to cover each component in a little bit more detail. So as I've alluded to, goals of care discussions are conversations between people, a patient, a clinician, a surrogate decision maker, to support understanding and sharing values, goals, and preferences for future medical decisions. In advanced care planning, these are necessarily iterative because values, goals, and preferences change over time, and they're often anchored to inflection points in life or an illness trajectory. For instance, somebody changing care setting, a progression of an illness, a response or lack of response to a treatment. The conversations themselves aim to elicit someone's health and illness understanding and establish a shared understanding to make sure everyone in the room is on the same page about what's going on, to establish someone's goals and values. And assessing goals and values can include questions like, when you think about the future, what worries you the most? Given the situation, what are you hoping for? And what's more important to you, most important to you in the coming time? The next step is to align with the patient's values. Alignment can include statements like, what I'm hearing you say is that being with your family and being comfortable are the most important things to you. What else is important? And then asking for permission to make a recommendation about a treatment that aligns with values and goals. So you could say, given comfort and being around your family is most important, is it okay if I share with you some recommendations to help achieve those goals? This might be an in-the-moment conversation about next steps in care. It might be many months or years upstream, a more hypothetical conversation about what kinds of care a person might want in the future. So advanced care planning and advanced directives, how are those two things related? I want you to think about it for a second and try to put them together for yourself. So advanced care planning is the process, and advanced directives are the documents that we might fill out in response to that process. An advance directive is a written legal document that gives provisions about future medical care. There are two big examples. One is a durable healthcare power of attorney. In New York, we call this a healthcare proxy, and a living will, both of which are informed by goals of care discussions. To start with the durable power of attorney for healthcare or healthcare proxy or healthcare agent, this is a legal document that grants authority to a named person to make decisions for another person and comes into effect when the person making this loses capacity. One interesting thing about this is the amount of authority that's granted to the healthcare proxy varies from state to state. For example, in New York State, where I practice, unless your healthcare agent reasonably knows your wishes about artificial hydration and nutrition, they're not allowed to refuse or consent to those measures for you. So there are some specific pieces that they can and can't do. All states in the US have a healthcare proxy law in place since 1997, which details the limits of the healthcare proxy. A couple of specific things about this. The form needs 2 witnesses. There's an option to assign an alternate proxy who would come into effect if the primary person's unavailable, unwilling, or unable to act as proxy. A proxy must follow prior expressed wishes or treatment instructions unless they have reason to believe that those wishes might have changed or they don't apply to the current circumstance. This is just to show you what a typical healthcare proxy form looks like. This is the one in New York State that I use all the time. And the sections include an option to put an alternate agent, to state a date or circumstance where the form might expire, the option to specify wishes and treatment limitations, and to limit any part of the agent's authority to make decisions. What do you do in the absence of a healthcare proxy? I've certainly been in this situation a lot of times, and I imagine many of you have too. What do you do if someone loses capacity and they have not selected someone to make decisions for them? It can certainly get sticky. So this happens all the time on our palliative care service, where we're called to see a patient with no healthcare proxy who's lost capacity and asked how to proceed. And the answer in every case here is to defer to your state laws about the automatic succession of decision makers, called the surrogacy ladder. This varies state to state, but in every state, the highest person on the ladder is the spouse. And one thing to note is that in order to act as a surrogate, an individual must be over 18 or 21, depending on the state, and in some states, emancipated minors can serve. And the laws for managing disputes among surrogate decision makers varies from state to state. In some places, the majority rules. In some places, you need consensus, like in New York. In some places, a medical practitioner can select the surrogate who appears to be the most qualified. So an example of the surrogate list in New York State is here. This is from the Department of Health website. So the spouse, if not legally separated from the patient, or the domestic partner, a son or daughter 18 or older, a parent, a brother or sister 18 or older, or close friend. And interestingly, in New York State, it's consensus rule. So if a person has multiple adult children, they all need to be contacted. And you could imagine how complicated that could become if people are disagreeing with each other. The other form of advance directive alongside durable power of attorney for healthcare is the living will. The living will is a document that contains guidance or specific instructions for making healthcare decisions. And this is direction coming from the patient. One thing that's important to note here is it's not a medical order, which is unlike MOLST and POLST forms, which I'll talk about in detail next. A living will can be helpful in supporting decision makers at the end of life, but very often it's too vague or too specific to be that useful. So for instance, I shared in the beginning that my grandmother had a living will that very clearly detailed her wishes in certain circumstances, but the circumstances she actually found herself in were quite different from those she had detailed in her living will. This is example text provided by the New York State Attorney General for people to consider including in their living will. So it says, I direct my attending physician to withhold or withdraw treatment that merely prolongs my dying, if I should be in an incurable or irreversible mental or physical condition with no reasonable expectation of recovery, including but not limited to A, a terminal condition, B, a permanently unconscious condition, or C, a minimally conscious condition, in which I'm permanently unable to make decisions or express my wishes. So thinking about putting this into practice, this can be helpful if a patient clearly fits into one of these situations, but very often the clinical situation is less clear-cut than those here. In practice, I find that living wills often only reference not wanting life-sustaining treatment if someone's in a minimally conscious condition for a long period of time, which I find to be a pretty rare situation to encounter in clinical practice. I want to talk next about a kind of advanced directive that I find to be much more practically useful. Depending on where you live, you might call it MOLST or POLST. And MOLST and POLST, in contrast to living wills, are actual medical orders for life-sustaining treatment that are intended to be portable and used across settings. It stands for medical or physician orders for life-sustaining treatment. The MOLST or POLST process aims to elicit and document preferences for life-sustaining treatment on a standard medical order form. How did this come about? This originated in Oregon in 1991 in response to the inadequacy of living wills, which we've just talked about a little bit, and were designed to allow people who are seriously ill or with advanced frailty or at the end of life, who frequently might require emergency care, to choose certain healthcare treatments when they can't speak for themselves. The effects of MOLST and POLST are to turn those decisions about care into actual medical orders that people in the hospital can follow. And they're designed to be completed by the healthcare provider to reflect patient preferences. I've included the National POLST form as an example of a form to familiarize you with this. So the POLST form has a section A, which talks about preferences for CPR, section B, which talks about initial treatment orders, whether someone would want full medical treatment, selective treatment, or comfort-focused treatments. Section C talks about other orders, including things like renal replacement therapy and blood products. And section D talks about artificial nutrition, hydration, or tube feeding. So the MOLST or POLST form does not automatically expire at any point, but should be reviewed when someone's transferring between care settings or levels of care, when someone has a substantial change in their healthcare status, when they change primary provider, and when someone changes his or her treatment preferences or goals of care and wants something else written on the form. So what about the controversy around effectiveness of advanced care planning and future directions? And I want to talk about some of the controversy. And I'd say basically the controversy is about whether advanced care planning is effective or whether it's a waste of time and resources. Some of the juicier publications in the world of geriatrics and palliative care over the last 5 years have looked like these ones. So you may have seen this: Advanced Directives and Care Planning, Clear, Simple, and Wrong. And this was written by the chair of our department, who was our speaker yesterday morning. So I want you to think for a moment about patients that you've cared for. Are there situations that come to mind where upstream conversations about care preferences and values have not been helpful for the patient in front of you? Some of the situations that come to mind for me are where we can't access information or documentation in a timely way so that it doesn't help the patient in front of us. So for instance, patients who indicated not wanting CPR, but end up intubated in the ED because people didn't know these wishes, or situations where people have indicated care preferences that don't track with an actual available care pathway. Or the situation that comes up fairly often where a patient has indicated wishes, but their surrogate decision maker disagrees and wants the patient to choose, wants to choose a different path than what the patient had put down. So what do studies tell us about whether advanced care planning works? The last couple of decades have witnessed the development of many, many advanced care planning interventions. And one thing to note is that there's been a lot of variation in terms of what these interventions look like and what they target. So some of the interventions have targeted behaviors like values identification, communication, documentation. They have different components included. Some are written, some are facilitated discussion, some are multimodal. They've involved a number of different actors, patients, clinicians, surrogates, a combination of any of the above, different disease groups, including cancer and non-cancer patients, different settings, often in the outpatient, but can also be in the community, inpatient, or nursing home. So to emphasize, interventions can target patients, surrogates, communities, clinicians, or all of the above. And many outcomes have been studied at the patient level, caregiver level, and healthcare system level. The outcomes are also quite heterogeneous. So process outcomes, including readiness for advanced care planning, action, for instance, completing an advanced directive or having a conversation, health status, including quality of life, anxiety, quality of care, including satisfaction with communication and care, as well as receipt of goal concordant care at the end of life, and utilization of healthcare, including ED and hospital admissions and days at home. So a lot of different things have been looked at. And overall, in all of those studies, there's limited evidence that advanced care planning improves the chances of receiving goal concordant care. And remember, that's really our gold standard of what we're trying to do with advanced care planning. To go into it with a little bit more depth, I'm going to highlight a couple of really important studies in this area. So in 2018, Jimenez et al. Undertook a systematic review designed to support policymakers and health systems leaders looking to implement advanced care planning interventions. The authors synthesized evidence from 80 systematic reviews over 1,600 articles. Overall, what they found was limited low-quality evidence of the benefit of advanced care planning in terms of increasing end-of-life communication, increasing documentation of care preferences, a slight increase in dying in the preferred place, and a decrease in healthcare costs. They did not show higher quality. They did not show that advanced care planning interventions led to goal concordant care, that they improved patient or surrogate concordance, so understanding of a surrogate understanding of patients' wishes. They didn't improve satisfaction, and they didn't improve real-time end-of-life decision-making. A more recent study, so in 2021, Rebecca Sudore's group undertook a scoping review of the literature and planned to include advanced care planning studies published between 2010 and 2020. In this scoping review, they rated 65 of the studies as high quality. 70% of them were published since 2017, and 62% were based in the US. The majority, 71%, were based in outpatient settings. The interventions that they included facilitated discussions, video interventions, interactive education programs, written materials, and clinician training. And they classified outcomes according to the ACP outcomes framework, which was a 2017 Delphi process to define the outcomes relevant to advanced care planning, because that had been quite controversial. So they included process outcomes like patient readiness to engage in ACP, action outcomes, which included communication and documentation, and care quality outcomes, including the receipt of goal concordant care and satisfaction with communication and care, as well as health status outcomes, including anxiety and quality of life, and healthcare utilization. In this, they found no relationship between advanced care planning and patient quality of life, receiving goal concordant care, and healthcare utilization or use of non-beneficial treatments, meaning that at the end of life, getting some invasive treatments is seen as non-beneficial because some patients might not want to be receiving those toward the end of life. More recently, actually very recently, a study was published in JAMA Internal Medicine this year. This was a large primary care-based advanced care planning intervention. It took place in Maryland with residents 65 years of age and older with serious illness who died within 1.5 years of study entry. People in the study got a letter from their clinic, access to a trained advanced care planning facilitator, a checklist, a portal, mailed advanced directive, and print education. They included more than 22,000 patients in the intervention arm. So a really big, very well-organized study. What they found was that those in the advanced care planning arm had more documented end-of-life preferences. So at 12 months, 12% of the intervention arm versus 6.6% of the usual care arm had documented something about end-of-life preferences in the electronic medical record. But one thing they found was that potentially burdensome care at the end of life was actually higher in the intervention arm, where people had had access to all of these advanced care planning interventions than in the usual care arm. So another big negative study in this area. So putting the studies together, we have evidence that advanced care planning interventions can increase the number of advanced directives. They can increase the likelihood that an advanced directive is in the medical record. They increase the number of advanced care planning conversations which are happening. And they increase, to some degree, the satisfaction with the process of the advanced care planning process. But there is no strong evidence that advanced care planning increases actually receiving goal concordant care at the end of life, which is really what we're hoping for with this process. There's no strong evidence that it changes the quality of end of life care. And there's no strong evidence that it improves patient or surrogate satisfaction at the end of life. Why is this? It seems like such a good idea to do this, and it seems so well-intentioned. One of the things that seems to really come up when we look at this is that it's really difficult to anticipate future medical decisions and likely outcomes. It's so hard to, the situations that we find ourselves in are so nuanced, it's really impossible for a form to capture all of the possibilities of decisions you might want to make and the outcomes related to them. It's also hard to predict the context of future decisions. So people's preferences are influenced by a lot of things: age, function, worry about caregiver burden, financial resources, and many other things. And it's also difficult to impact goal concordant care with advanced care planning, given all of the structural barriers to actually providing goal concordant care. So, one example that comes up all the time in my work in New York City is people expressing really, really wanting to be at home for end of life care, but to actually be cared for in the home at end of life requires extraordinary caregiver financial resources to be able to do so. So sometimes the things that people are hoping to plan for may not be possible within the confines of the systems. So, what should we do instead with all of this? Where does this leave us? The recommendations that I would leave you with are to really focus your attention on appointing trusted surrogates. If we can help patients pick somebody that they really trust to help them make decisions, that can be really useful in the moment. We can spend our work helping improve illness understanding for patients and their people and prepare them for in the moment decision making about real decisions that they're going to need to make. And let's focus on conversations about hypothetical future situations, which is more the focus of traditional advanced care planning. So, in summary, advanced care planning is a process through which adults are supported to understand and share their values, goals, and preferences for future medical care. The pieces of advanced care planning include choosing a trusted decision maker, preparing for future in the moment conversations, having conversations about future treatments, and documenting those wishes about future treatments. And I would suggest that we really focus on the bold things here. So, helping people choose a trusted decision maker, a healthcare power of attorney, or healthcare proxy, and preparing people for future in the moment conversations. To move toward those focuses of the people in the moment conversations, not the hypothetical treatment decisions. And I will leave you there.
Thank you so much, Molly. I think a couple of questions do come up because it's such a switch in how we're thinking about advanced care planning now. And I wonder if how you kind of ask clinicians to approach this. It sounds like choosing a surrogate is really important and making sure that's in place and the documentation for the surrogate is in place. Are there ways that you think we can help to prepare both the surrogate and the patient while they might still have capacity for their role?
Oh, such a good question. I think a piece of it is really good communication with patients and surrogates about sort of what we expect down the road with their illness. So making sure that they really understand kind of where they're at and the decisions that might be coming down the road for them so that they and their surrogate can really talk through those things and be as prepared as possible. I know it's not possible to sort of predict every possible part of it, but really understanding what someone's goals and values are and getting some comfort with talking about those things, I think can be really helpful.
And do you have strategies that you implement or you suggest to your fellows to try to get people to start to think about maybe some of the hypotheticals that might come down the pike for somebody's particular illness?
That's a great question. So I think we have a couple of excellent talks during this week about communication strategies. And one that I think is really helpful is asking permission. So asking people through what they know about their illness. Are they somebody who wants to know more about it? And making sure that those things are in place before we give them a lot of information. But I think we find that most people want to be prepared and want to know sort of what you as the clinician are expecting coming down the road. So I think structuring those conversations in a careful way, so you're making sure that it's the right time, that the right people are there, that you really you're not just jumping in to unload a lot of information on them, but that you have asked permission before you do that. It's really helpful.
That's a great point. I think just helps to set the stage, get everybody ready, and gives the patient a chance to think like, am I ready to hear this? So I love that point. Thank you so much.